When a patient arrives with a suspected acute stroke, every diagnostic decision is constrained by a rapidly closing biological window. With every passing minute, millions of neurons are starved of oxygen. In this environment, frontline clinicians rely on standard stroke acronyms and basic physical tests. Yet these tools frequently mask the most catastrophic events, large artery occlusions, or LAOs, until the intervention window has already closed. This matrix compiles 24 clinical stroke scales, visualizing the high volume of variables clinicians navigate. Analyzing these for the 10 most common signs reveals a clear limitation. The average accuracy across all systems is just 77%. This leaves a significant margin for error. We must determine which individual clinical sign carries the highest predictive power for a large vessel occlusion. We also have to identify the subtle brainstem signs that bypass these standard pre-hospital screens. By reverse engineering this data based on specificity and positive predictive value, we can extract the definitive predictors of an LAO. Filtering the noise of triage requires moving past foundational low specificity symptoms to isolate the clinical outliers. Building a predictive model begins with the most frequent metrics. Tests for facial and arm weakness appear in the majority of these 24 scales. While universally checked, facial weakness has a positive predictive value of only 20% and arm weakness is 25%. The first indicator is severe lateralizing focal motor weakness. That means weakness strictly on one side of the body. The risk of a large vessel blockage spikes if this weakness involves more than two areas, like the upper extremity, the lower extremity, and the face all at once. The second major predictive category is new speech and language deficits, specifically dysarthria and aphasia. The anatomical depth of the language deficit directly correlates to the likelihood of major anterior circulation involvement. The deeper the deficit, the higher the probability of a proximal occlusion in the middle cerebral artery. Standard pre-hospital exams often stop here, assuming that identifying aphasia and weakness provides a complete diagnostic picture. While these motor and speech signs offer high sensitivity, they lack the specificity required to definitively confirm an LAO without further evidence. To find that evidence, we have to look at high-yield outliers in the data that can cut through diagnostic noise. Returning to the matrix, look at the row for gaze deviation. Forced eye deviation, or a new visual field deficit, has a positive predictive value of 85%. This is the most powerful clinical sign pointing to the presence of a large artery occlusion. Forced gaze locks the patient's eyes directly towards the ischemic hemisphere of the occluded vessel. This gaze is often further supported by severe head and neck deviation in the exact same direction. The fourth predictive category is new anosognosia, also known as denial or neglect of the deficit. This sign carries an 88% specificity and an 88% negative predictive value. Patients with this abnormality are often neurologically incapable of telling the examiner they have a deficit. Neglect can mask the severity of a stroke from clinicians who rely solely on patient feedback or self-reporting. Any triage scale that omits gaze deviation and neglect misses the two signs with the highest statistical correlation to a catastrophic LAO. These major signs must be framed within strict physiological parameters to rule out mimics. Mandatory inclusion criteria for an acute stroke diagnosis include symptom onset under 24 hours and a blood glucose level strictly bounded between 60 and 400 milligrams per deciliter. Red flags like new gait imbalance or a new seizure can also assist in the suspicion of an acute event. However, the 24 scales in our matrix show a significant diagnostic bias toward anterior circulation strokes. Acute ischemia in the posterior fossa presents a different profile that is frequently overlooked by standard metrics. The primary presentation is a decreased level of consciousness. To confirm a posterior event, clinicians must explicitly test for absent swallowing, either spontaneous or on command, and an absent cough. Standard FAST acronyms do not prompt the clinician to check these reflexes, which can lead to a missed diagnosis. A locked-in lower brainstem presentation will be missed by clinicians who rely solely on the anterior biased metrics found in standard scales. To apply this data in a pre-hospital or emergency environment, we must organize these findings into a practical protocol. We can structure these high-yield predictors into a diagnostic mnemonic. Magnet. M is for lateralizing, multi-limb motor weakness. A is for aphasia or dysarthria. G is for gaze deviation, the strongest statistical predictor of an LAO. N is for neglect or anosognosia. E stands for evidence, specifically video documentation. And T is throat reflexes, requiring an assessment of swallowing and coughing. The evidence step is a logistical tool. Taking a 15 to 30-second video of focal deficits bridges the communication gap between the field and the hospital. Dynamic video handoffs provide visual clinical detail that verbal acronyms cannot convey to an interventional radiology suite. On your next shift, prioritize an assessment for gaze deviation and neglect to identify possible large artery occlusions. Additionally, explicitly test for swallowing and coughing to identify hidden posterior fossa strokes. Use the MAGNET mnemonic and share it with your local stroke response teams to standardize the detection of catastrophic vessel occlusions.